Good afternoon, everyone. First of all, thank you very much for joining us in this session we are hosting today from the Specialized Working Group Infections in Hematology from the European Hematology Association. It's a great pleasure to have Professor Rodríguez Morales from Colombia being the speaker for it. It's a quite different topic, especially in certain latitudes. Yellow fever in hematological malignancy patients, but still it's we think it's pretty interesting. So I hope, or we hope, you can learn many things today from him. As you know, there will be time for questions and answers that will be at the end of the session, but you can already start typing them in case you have any already in the chat of this video call. The presentation is getting recorded and we will make it available later on in our YouTube channel. And last but not least, Professor Rodríguez Morales has posted in the chat. I don't know whether the newcomers can see it or not, but I mean, like, he can type them afterwards. His social media, and I'm also posting right now basically the message that you are free to make any question anytime, and also a link to WhatsApp group with information on further webinars. So having said that, thank you very much. Muchas gracias, Alfonso, for joining today, and please, the floor is yours. Thanks a lot.
Well, dear John, thanks for the introduction and the brief presentation. As has been said by John, my name is Alfonso Rodríguez Morales, and I work in tropical diseases. And over the last couple of years, we have been facing a very important outbreak of yellow fever, and we will discuss on the general aspects of this, but especially in the context of hematological malignancies for different aspects and purposes, as has been already announced. I have no direct conflicts of interest for this presentation. However, I worked with vaccines for other arboviral diseases, including dengue, chikungunya, Zika, and for that reason, I also show this, but there is no direct conflict for this presentation. Well, in the following 40 minutes, the idea is to cover some of the general aspects of yellow fever, as well focus on the risk for hemato-oncological patients with the focus especially on Latin America, which is facing an important outbreak of yellow fever since 2024. And secondly, we will speak about the vaccination in different scenarios from the general point of view, then after arriving specifically to the problem with immunocompromised patients, and particularly in hemato-oncological patients. Well, for many people, yellow fever is not a common disease, but what is important is when we speak about yellow fever, this is a very important disease in certain tropical areas. I will discuss later the epidemiological aspects in detail. But this is a viral disease. This is a flavivirus that is causing the disease. But the most important is that yellow fever is an arbovirus. And as an arbovirus, this disease implies that we have arthropod involved in the transmission. These arthropods may include ticks, not for yellow fever, but for other diseases that maybe you are more aware of it, like tick-borne encephalitis or the case of Crimean Congo hemorrhagic fever, both present especially in certain countries in Europe. But this is among the group of mosquito-borne viruses. And as you see, we have different types of life cycles. we have a disease that is maintained fundamentally among non-human primates, monkeys, different kind of monkeys. I will comment briefly on this, but this is important in South America and in Africa. And in the nature, this is maintained by different mosquitoes, including particularly the case of Savitis and Hemagogus that are wild vectors of yellow fever among other potential arboviral diseases or other arboviruses. And the humans, when entering sylvatic areas, for example, here in South America, in rural areas where there is transmission, where there are the vectors, the tropical conditions as well, the monkeys may get infected. But there is also a risk for transmission in urban areas as it is a more common, in fact, vector, which is the main vector of dengue, but also is a vector for chikungunya and for Zika, is present in urban areas in Latin America as well, for example, in other regions. And this represents the possibility to have, in fact, urban transmission. Fortunately, this has been considered a rare event, but it may occur. The last time that was documented was in 2018 in the city of San Lorenzo, very near or close by to the capital city of Paraguay. But in the past, before that, in many areas, many urban outbreaks, especially at the early of the previous century, were reported in regard with yellow fever in urban areas. You may see here the virus, and as I told you, this is a flavivirus, as with the rest of flavi and the rest of, in fact, of arbovirus, this is a RNA virus, and this may have certain implications that we may discuss later. And as I told you, this is the main transmission, the vector-borne transmission. But as we will discuss, especially this is important to consider in non-endemic areas, there is the possibility of non-vector transmission, including the fact that when a patient with yellow fever infections had, for example, a viremia, there is a possibility of blood or transfusion associated infection, but also there are other scenarios where these may be related to non-vector transmission, as we will discuss. As we published in Lancet Infectious Disease some years ago, this is one of the arboviruses that we have, for example, present here in Latin America. It's very important in history and is present in at least a dozen of countries that are considered endemic. But the transmission, fortunately, is not continuous. This is sporadic, and we have seasons of yellow fever right now. Since 2024, as I mentioned, we are right now in a yellow fever outbreak currently in some of the countries of the region. But from a clinical point of view, and I will later detail, as I mentioned, on the update epidemiology, yellow fever is a systemic disease. It may affect any organ. It's very similarly clinically with other arboviral diseases, including dengue, chikungunya, Zika, Mayaro, which is another endemic arbovirus in Latin America that, in fact, may be associated also with imported cases. For example, in Europe, has been reported in many countries in imported cases, but more recently and even important, the case of Oropuche, which has been also reported as imported cases outside Latin America, including the case of the Caribbean island, North America, including United States, Europe, in multiple countries in Europe. There has been report of Oropuche, including the case of Spain, France, Germany, Canada, and particularly Italy, in travelers returning from Brazil and from Cuba, among other examples. But what is important, as you may see here, This is a key important clinical finding, which is jaundice. This is a enteric hemorrhagic syndrome. So you may have also hemorrhagic disease. This is among the, the group of hemorrhagic, viral hemorrhagic fevers. There are obviously many others in the differential diagnostics in Africa or here in Latin America, including the arenaviruses. We have different arenaviruses here in Latin America, the Venezuelan hemorrhagic fever, the Argentinian hemorrhagic fever, the Bolivian hemorrhagic fever with high case fatality rates. But the other very important aspect is the hepatic compromise. This is a very important clinical feature, the hepatic involvement, and will be translated in other findings that I will comment. But as you may see here, there is a obviously fever, high fever with sudden onset, even including the so-called Faget sign, which is a relative bradycardia. That means in the scenario of high fever, you have patients with bradycardia, which is the opposite to expected, for example, with fever. So you have a biphasic disease that I will show you in a more graphic way. You have a high case fatality rate, as I will showing also, and the hepatic involvement, which is very important. How we define a case of yellow fever? And I will not stop in all the detail, but I would like just comment particularly emphasizing on the fact of the fever, but jaundice appearing within 14 days of onset of the first symptoms. But with that, consider the epidemiology and consider the possibility to perform laboratory tests. Particularly, the most important is the PCR. In fact, the RT-PCR, reverse transcriptase polymerase chain reaction, is when you may have a confirmed case. And this is very important because it's required to speak properly of a real case of yellow fever. There are other possibilities, and I will not stop initially on this. Maybe if you have later doubts or questions about it, for example, the type of samples in addition to blood that we may use to detect yellow fever, we may address that later. But then, recent experience we have show that if you are not vaccinated, the risk of high probability to have not just the disease, but leading to a severe and even fatal case is quite important. For example, in the recent series, more of them have no vaccination, and we have 57% of the patients that died from yellow fever in this study from Bolivia, Ecuador, Colombia, and Peru. We published the last year. But in addition to those clinical presentations I commend, it's important to consider that, in fact, patients may lead to severe disease with multiple kinds of complications. In fact, we speak many times that a severe disease of yellow fever is similar in many aspects to the clinical presentation of sepsis. But you may have many other things you have to consider, for example, a central nervous system compromise, super infections, even co-infections, among other things. In this recent publication from our colleagues from Brazil, is highlighted, for example, the pulmonary complications, even with the super infections with bacterial pathogens, as you may see, some very common, but others not necessarily. And these may be associated with severe disease and obviously in a high proportion of cases with a fatal outcomes. For our study, I would like to highlight that especially the hepatic compromise is associated with figures like this when you see really elevated values of AST and ALT in addition to other main hematological alterations, including leukopenia, thrombocytopenia, anemia, hemoconcentration, the coagulation times alter, prolonged. You may have a patient when it's in a severe disease with disseminating intravascular coagulation, with elevation of the fibrin degradation products, as well the D dimer among other alterations you may see. And as I mentioned, with the cross circulation of other arboviral diseases, including dengue, you may have even, as we observed in this series, also the possibility of co-infection. Here we may summarize the fact that, in fact, in this disease, we have also cardiac impact of yellow fever. I will not enter in each of the details, but would like to highlight from these very important studies published at the American Journal of Cardiology some years ago that 52% of the patients had significant electrocardiographical abnormality, which is important to consider in these patients with mild and moderate yellow fever to perform the ICG. But even more, in those with severe disease, this figure increased to 77% of the patient with alteration, which obviously include impact of the myocardial function with myocardial infiltration, and sometimes even with myocarditis and myocardial necrosis among other alterations. So, summarizing the clinical progression of yellow fever, it's interesting to mention, as I already did, that we have a disease in different phases. We have the initial phase of infection and remission. You may see the patient is even improving from the clinical presentation. But after that, after a few days, less than 5 days, some patients may progress to the severe disease, which is called the intoxication stage, with where you may have this multi-organ failure, and where you see those kind of alterations I already mentioned, which is important to highlight that this, for example, AST and ALT will be observed in levels that are 2 times higher than the upper limit of the normal value. Normally, with a higher value for AST than ALT, which is around 3 times higher for AST than ALT. And in this stage is when the case fatality rates may be ranking up to 60% of fatal outcomes on these patients. But this figure may be higher among certain population and certain factors. And this again is raising data from the ongoing outbreak, in this case in Colombia, Brazil, and Peru. And as you may see here, and this is a very complex table, I am not trying to read or explain in detail, but what I would like especially to highlight is the fact that if you see the case fatality rate among people younger than 60 in these 3 countries with very good surveillance, and most of the cases of yellow fever in the region, as I will show you in few moments, is around 30%. 30 from 100 patients with yellow fever died in this group. But when you see that value among those elder than 60 years old, this is more than 65%, which means that this is more than double of the case fatality rate based on age. And you may see even there are a gender difference that should be also take in consideration. So we have vulnerable populations that may be obviously evolving with a more severe disease, and that is the case of immunosuppressed or immunocompromised patient, and has been reported in some cases. This case that was a kidney transplant patient that unfortunately was exposed and developed yellow fever in an endemic area, in this case in Brazil. And this highlight the fact that yellow fever in immunosuppressed patients, as this one, may lead to rapidly progressive disseminated infection with severe hepatic failure and multi-organ involvement, even probably being higher than in immunocompetent patients, often resulting in a fatal outcome within days, as illustrated in these reported cases. But the problem is that we have to be very careful among those patients that are actually with severe immunosuppression, because not just the wild virus is associated with disease. and transmission. But we have this report in Lancet Microbe 2023, where you may see that the vaccine virus, remember we have a lead uh, attenuated vaccine, this has been associated also with transmission of this vaccine virus through blood transfusion and organ transplantation, even in non-endemic areas, as this case in the United States in 2021. And these were 4 cases that unfortunately 2 of them recovered, but other 2 had no neurological recovery and died from disease associated to the vaccine. This is really, really rare, but it may happen when you have severe immunosuppression, and this should be carefully assessed in these patients. In this case, these were one of the yellow fever cases in a cerebrospinal fluid was detected in one recipient of a kidney, and these patients unfortunately had severe disease. And for example, the blood transfusion from a donor, one of them received, was from a person that vaccinated with yellow fever 6 days before blood donation. So this is also a very important aspect for the assessment when you have, for example, blood donation or obviously organ donation, to assess not just the screening for infectious disease, but also the screening for vaccines, lead vaccines, such as the case of yellow fever vaccine, among others. So we may summarize from recent literature that the clinical impact of yellow fever among immunosuppressed patients is important. We have the increased risk of severe disease. We have the possibility of progression to toxic phase more likely, elevated rates of multi-organ failure, incidence in major incidence of fatal outcomes, exacerbated hepatic involvement with severe acute hepatitis, with hyperbilirubinemia, with increased risk of acute liver failure, and this will be really hard to manage. And we have published recently, I will not stop in detail of this, but I would like just to show you, and this is an open access publication in Lancet Regional Health Americas. We developed a consensus for the management of severe yellow fever from different points of view, trying to be close to the evidence-based situation, and it's important for the management of severe yellow fever in our experience here in Latin America. Continuing, we may mention, obviously, hemorrhagic complications, disseminated intravascular coagulation, gastrointestinal bleeding, which is commonly common and historically common, blood vomit from many centuries, the thrombocytopenia that can be more profound and persistent. And we have, obviously, from this autoimmune response, problems for the viral clearance. So there is a risk of higher viremia, and in fact, viremia in yellow fever, which is not common in other diseases, uh, um, is also a prognostic. Higher viremia is associated with worse prognostic in the patient. In this setting, we may have also dysregulated cytokine response, a reduced ability to control systemic infection, and finally, this may also represent among this population diagnostic and management challenge for different aspects. But I would like to highlight that it's important to consider the epidemiology, which we'll discuss now, of yellow fever, not just for people living in endemic areas, but particularly traveling to endemic areas, which is a very important assessment we should do in patients, especially those at higher risk of severe disease. And our main discussions, and we will enter now on this topic, is the vaccination limitations, because we have just one kind of vaccine, which is a live attenuated vaccine, which is the 70D strain, which is contraindicated if there is severe immunosuppression. However, we may discuss the risk benefit in the scenarios of the possibility of this is possible, And this obviously creates a potential prevention gap in high risk population, and we will discuss on options of this. Briefly on epidemiology, you may consult this site. I will later during the question and answers left the PDF of this presentation for everybody. You may access these sites and all the information. And this is what we have: more than 465 confirmed cases by PCR in 7 countries. But why? We are speaking a disease that during 2 years has caused less than 500 cases. Because the problem is not just the number of cases, but look at the number of fatal outcomes. So we are speaking that more than 40% of the patients died actually from yellow fever in Colombia, Ecuador, Peru, Bolivia, Brazil, Guyana, and Venezuela over the last 2 years. But we have to remember that we have yellow fever not just in South America. It's important to mention that this is the main area of transmission. We don't have outbreaks over the last decades in Central America and the Caribbean, as well in the South Cone in countries such as Chile or Argentina, despite other discussions we may have regarding these countries that are with no active circulation of yellow fever in this region. But the other important thing is to remember that we have endemic yellow fever in countries of Africa. In tropical Africa, you may have a very important areas and countries with transmission and areas where obviously protection, including the vaccine, will be necessary. Such maps are being updated usually annually. And you may see here, this is info from the Center for Disease Control Yellow Book latest edition that you may find in this address. And you may see here the update regarding the maps, the areas where, for example, in this intense orange color is vaccination actually recommended for the case of South America as well for the case of Africa. But again, if you may consult specific epidemiological maps, for example, from Colombia, you may see that not the whole country is endemic. And in fact, there are areas where no even the vector is available, such as the capital, Bogota, that is above 2,000 meters above sea level. Then the vector is not even present in this, and in fact, other high altitude cities. So a vaccine will not be necessary at all because no possibility of vector-borne transmission is in those areas. But this is important to consider the specific epidemiology. And a tool that maybe is interesting if you have a traveler that is coming, for example, to Colombia is this, because in this map we are updating daily the risk areas, and the important is here in the red where there are risks of current transmission, and secondarily here in yellow with recent historical transmission, but in blue areas there is no transmission at all for very long time, or in fact there are no vectors at all. You may see here uh, also the epidemiology, the situation, what is going on in the last epidemiological weeks, the number of cases, and similarly, you may consult this, for example, for Brazil, which is the other important country with outbreak. I would like to leave information from what is going on, but also you may consult the website at any moment to see what is going on regarding these epidemiological aspects. So let's talk about vaccination, which is the main message probably I would like to deliver regarding what we should consider about yellow fever. Well, we have to remember that if someone is exposed without the vaccine and in fact survived the disease, which obviously may occur, there is a very important immune response that usually is a long-standing as the vaccine among immunocompetent population. With one dose of the vaccine, usually most of the population will be protected for life. And this is a similar situation if you get infected. But the risk, obviously, is that you may develop a, an important disease, a severe disease, and even a fatal disease. So this is an important aspect to consider. And we have one vaccine that is produced by different manufacturers in different countries and different regions. I will not stop in detail on this, but you may see here and you may consult later the presentation. But what is important is, regardless who is producing the vaccine, among immunocompetent population, you will see, as I am showing here from the Ploxins vaccine publication, that the seroconversion is around 100%. So this is a very immunogenic vaccine. This is a very efficacious vaccine. And again, it's also a very safe vaccine that, in fact, even in immunocompromised patients can be co-administered with a long number of other vaccines, as I am showing here, even new vaccines, such as is the case of dengue vaccine, which is also a live attenuated vaccine that has been also licensed right now in multiple countries in Europe and abroad, and is being used especially in endemic areas. In travelers, may have the problem that this two dose with a separation of 3 months between those. But again, it's still also used for travelers going to endemic areas. And this vaccine can be co-administered at the same time with yellow fever. So, speaking specifically on data from the vaccine safety, I would like to highlight that in younger populations, this is a very safe vaccine where you may see that the rate of overall serious events is around 3 cases per 100,000 doses administered of this vaccine. That may increase in older population, obviously. This is important to consider. But again, you may see that this is a very rare event in the case of overall serious event, in the case of neurotropic, or in the case of viscerotropic disease. So when you compare this to actual risk of dying if you get yellow fever in areas where there is circulation, active circulation of yellow fever, obviously the benefit of the vaccine may be higher many times than the theoretical risk of having an adverse event. So, what is important initially on this discussion is that I'm not uh, advising to use the vaccine when you are not in an area of high risk of disease. So this is the first important key message. Yellow fever vaccine is recommended for people that are specifically to areas with yellow fever circulation. So this is not a vaccine for everybody. Even in immunocompetent patients, we don't recommend the regular use, the application of these vaccines for everybody, but just for those that are going to endemic areas with circulation and risk of transmission. And this is the first important aspect I would like to highlight. But again, this is a very efficacious, very safe vaccine, very effective. And if that is true, why do we have human cases of yellow fever, for example, in South America? Because unfortunately, the vaccines coverage, as you see here, are far from being ideal, which is 95% or higher. And you see here the rest of the countries, with the exception of Guyana, having, unfortunately, very low numbers for what we need to have in order to have a real protections against a yellow fever. So, when to vaccinate? Again, exposure risk. We have to assess that. If you have someone traveling to an endemic area with current yellow fever outbreak here in Latin America or in sub-Saharan Africa. And obviously, if you have someone with severe immunosuppression, you will not administer the vaccine. But if that is not the scenario, we have to assess in which scenario we may consider to apply the vaccine or even a booster, as I will tell later briefly. And this may include the possibilities of vaccinate people that in the past had any kind of immunosuppressing disease, but right now is in remission and is with a mild or moderate kind of immunosuppression. So this is another important aspect to highlight, which are the real contraindications and the precautions of disease. Obviously, if you are in any condition of severe immunosuppression, for example, for us it's very clear and among people with HIV, if HIV patients have less than 200 CD4s, this is totally contraindicated because there is a risk, as is a live vaccine, of developing a vaccine associated disease. And obviously, the rest of severe immunosuppressive conditions obviously are contraindications for the administration of yellow fever vaccine. But what is important is that there is a clear difference with precautions. Precaution, remember, means that we may use the vaccine, but this is a vaccine where we need to assess the risk and benefit balance for some specific individuals, including, for example, HIV, which is clear we may administer a yellow fever vaccine if there is no severe CD4 immunosuppression. If we have, for example, between 200 and 499 CD4 in the lymphocyte T lymphocytes count, and this is important also to protect if they can avoid to travel to endemic areas of if this is a population living actually in areas with high circulation of yellow fever. So here is when we start to discuss what happened with immunocompromised travelers, especially isn't justified vaccination hesitancy? That was a question that this paper at the Journal of Travel Medicine did some years ago. And from this paper, we may summarize that, in fact, in general, this vaccine is usually contraindicated. And in this scenario, travel to highly risk areas of yellow fever is obviously discouraged. But sometimes patients cannot avoid travel for work, for family studies. But the problems, and this is probably one of the main conclusions that we may um, end with this presentation in general, is that we have limited evidence. But again, we have selected patients that may tolerate the vaccine and develop antibodies and be partial or, let's say, protected in some way. But again, we have the risk of severe disease, we have the high case fatality rate, and this may outweigh the vaccine risk. It's important then to consider an individualized approach, consider the options for the travel if it can be avoided, what is the level of immunosuppression, because right now when we speak about immunosuppression, this is not black or white. We are speaking more or levels of immunosuppression. Obviously, again, if you have a severe immunosuppressed patient, the vaccine is totally contraindicated. But what happens if you have, for example, HIV person with 500 CD4s, or if you, for example, have a patient under methotrexate that you may reduce, for example, the dose to less than 10 or even 10 milligrams per week, that then is a possibility to vaccinate if you have a patient in a high risk area or with unavoidable travel to there. Obviously, there is no risk free and there is limited evidence. There are possible adverse events. This is important to monitoring, especially this population and uncertain. We have a long-term protection that need to be even assessed. We can test for antibodies, and this is important. And the main message from that question is to avoid relying only on waivers, and we need to consider case by case vaccination. Other articles, even older, as this one from Brian in France, consider that after cancer remission, sometimes the situation becomes less clear. And again, patients may no longer be severely immunosuppressed approximately after 3 months after chemotherapy. Obviously, these need to be assessed clinically and paraclinically, but unfortunately, in time, guidelines have been inconsistent, in part due to the lack of data or evidence, and yellow fever vaccines is still considered contraindicated or not clearly recommended in multiple scenarios. However, some expert practice suggests that vaccination may be considered after remission and immune recovery, and I will tell you a couple of the guidelines that speak specifically on this. But again, only with extreme caution and individualized risk benefit assessment. And this study is very interesting because this study is an evaluation of the safety among of the yellow fever vaccine in among allogeneic hematopoietic stem cell transplant recipients. And in this small study, they found that the yellow fever vaccination can be safe in carefully selected recipients, especially those with immune recovery, no graft versus host disease, and after stopping immunosuppressive therapy generally 2 years after post transplant. So, this is important because they do not observe serious adverse event in this small population. Vast majority develop protected neutralizing antibodies. The timing is obviously important. And it's important to remember that pre-transplantation vaccination is unreliable. Immunity from yellow fever vaccination before the transplant is often lost. So prior clinical vaccination cannot be assumed protective. This can be assessed with the antibodies. And finally, the clinical implication of this is that instead of systematic contraindication, yellow fever vaccination may be considered in selected post HSCT patients after proper evaluation. So, what to do? In patients with malignancies, the yellow fever, hematologic malignancy, the yellow fever vaccine should generally be avoided during active disease and or significant immunosuppression. But if travel to a yellow fever risk area is unavoidable, individual risk benefit assessment with an expert in the field is recommended and alternatives should be prioritized. But again, are there possibilities of vaccination? This should be considered. And two of the guidelines, which is important to consider, one more general and the other more specific and even recent, is one of the ASCO in United States that provides, for example, also very valuable information regarding to remember, for example, the prevention of household contact travelers. Especially remember that, as I already told you, yellow fever vaccine is important not just in endemic but not endemic areas when there is a risk of someone returning from an endemic area with yellow fever and to avoid such a possibility and other vector, non-vector ways to be transmitted. Yellow fever has been detected, for example, in sexual secretions. We don't know if it at the end can be or not transmitted sexually, but other arboviruses such as Zika, dengue, and maybe Oropuche are in that consideration, and we need to consider that. But other problems I already mentioned: blood, organ donations, transplantations. Even in the pregnancy, there is vertical transmission in the breastfeeding. This is already documented, so there are other ways. And from this guideline from ASCO, it's important to remember three things. The first, live and live attenuated vaccines should be delayed for at least 2 years and only given in the absence of active graft versus host disease or immunosuppression. Secondly, providers should address the issue of the live vaccine safety on a case-by-case basis in consultation with an infectious disease expert. And in third place, I would like to highlight from this guideline that, again, live virus vaccine should not be administered to HCT recipients for at least 24 months post-transplant, and obviously, if the recipient is at that time judged immunocompetent or not with an active severe immunosuppression. Recently, from the German Society for Hematology and Medical Oncology, this has been published in Lancet Oncology. And from this recommendation, this guideline of this infectious disease working party, it's important to highlight again, vaccination in yellow fever is contraindicating immunocompromised patients for all that we already mentioned. Nevertheless, immunization might be considered following a minimum of 2 years after completing immunosuppressive treatment. And patients in that scenario should be discouraged from traveling to endemic areas before vaccination. But also, it's important to consider that in this scenario, there appear, for example, to be no major safety concern, for example, in people living with HIV with the reduced CD4 counts if these are at least 200. Leak vaccines should be generally given only within 24 months post immunosuppression, and we consider these specific situations such as outbreaks and after individual risk benefit assessment. And an exception may apply for certain immunomodulatory agents such as lenalidomide, where there are some data about that. What we can summarize? We may summarize this in three stages. There is an absolute contraindication if you have any kind of severe immunosuppressive conditions, active hematological cancer, including leukemia, lymphoma, current cytotoxic chemotherapy, or stem cell transplant within 24 months at least. And if after that period of time and after remission, there is no immunosuppression, you may have, obviously, the use with caution in different scenarios, as we already mentioned. And if the patient has just a history of cure, solid tumor, surgery-only treatment, or those with hormone therapy alone are considered uh, outside of severe immunosuppression, generally is safe. Remember, we need to assess this scenario, and we have to consider this clinical decision framework. Finally, we like just to mention that patients that were vaccinated under this scenario where there is no real full immune state, is important to remember that probably after 10 years, a booster will be needed if they will be again exposed in this area. And this is a result from meta-analysis from my friend Dr. Growers from Amsterdam, showing that in certain scenarios, not is the case of the healthy adults, that 10 years more, 89% are still protected. But if you see, for example, the case here of people living with HIV, the figure significantly reduced to 65% or less. And you may see in other studies a similar situation with a reduction in the virus specific neutralizing antibodies if they are immunosuppressed. So while if the people is vaccinated while immunocompromised, it's important to consider the possibility of boosters for this population. And this has been advised, for example, in the United States by ACIP, as you may see here, but also, for example, in Germany by the STIKO recommendations that include people with immunodeficiency that maybe need to administer a second vaccine dose or booster in these scenarios where there is a possible exposure due to travel again. What we can conclude then from this, well, yellow fever remains a high impact threat in Latin America and obviously in Africa with high case fatality rates, especially during outbreaks. Patients with hematological malignancies are highly vulnerable. There is an increased risk of severe disease, multi organ failure, and death. more frequent hepatic, hemorrhagic, and immune dysregulation complication, diagnostic challenge due to atypical or overlapping presentations, and immunosuppression amplifies severity with the risk of higher viremia, impaired viral clearance, rapid progression to toxic phase, and fatal outcomes. Exposure risk is often underestimated, and then this is important from travel medicine. We use to do this regularly to assess this if there is ongoing transmission in the countries. We have to consider that there is risk even beyond strict rural settings. Right now, we have, for example, in Brazil and Colombia, peri-urban exposure, not in the proper urban, which is also a matter of discussion right now, especially in Sao Paulo, Brazil. There is a major dilemma in the prevention gap with the vaccines that we discussed. It's important to remember that we made advise, for example, use of nets, especially those impregnated with insecticides, the use of repellents, among other kinds of protection to avoid mosquito bites. However, the risk of natural infection, considering the aspect of the vaccine, may outweigh the vaccine risk in selected cases, always individually assessed. Then management must be individualized, and we need to assess the degree of immunosuppression and, again, the exposure risk depending on the places the patient is going. Then we need to consider deferring travel, as I mentioned, strict mosquito prevention, medical waivers, because other important aspect that we need to consider and to discuss when we speak about yellow fever vaccination is that if you are traveling to certain countries, there is a mandatory presentation of the yellow fever vaccination certificate. If the patient cannot be vaccinated because any of the contraindications, we need to provide medical waivers, and we need to assess, obviously, the situation and the risk of acquiring disease beyond all the efforts to avoid, for example, mosquito biting. Finally, selected scenarios where vaccination may be considered: post-immune recovery, as we mentioned, mild or controlled immunosuppression, always under multidisciplinary evaluation. And we have to consider this key clinical measure. We have to avoid one-size-fits-all decisions. Obviously, we had to apply personalized risk-benefit assessment, case by case. And also, we have to consider this is part of the public health priority. We need to improve the vaccination coverage, especially in general population. And again, we have some kind of protection for vulnerable patients through indirect or herd protection if we have a high coverage rate of yellow fever vaccination, which unfortunately not always is the best, even in endemic areas, as I already showed. So yellow fever continues to be very important, and we have to protect to this disease in different scenarios, as I mentioned, not just for the case of Latin America, obviously also to Africa, and we need to consider other vaccines that may be necessary according to risk, and obviously consider the specific vaccines and their considerations in terms of safety for different patients. I would like to conclude this presentation as the poet Luciano Garcia Gomez in my city calls. In Pereira, there are no foreigners, we are all Pereirans. Thank you very much. And if you have questions, these are more than welcome. Let's see if there are questions in the chat. Unfortunately, for this session, as it's a holiday in the Netherlands where this is hosted, right now I am alone. So here there are questions. Well, the first comment, awesome presentation, Doc. Thank you very much. What is the laboratory diagnosis of yellow fever? Again, I already mentioned it's quite simple in terms of we need a blood sample, and what we use is a molecular diagnosis, RT-PCR. The PCR is the corner of diagnosis, not just for yellow fever, but in fact for many other arboviral diseases and for many other pathogens. And in most countries, this is available in reference labs. This is not usually available, for example, in most hospitals, even in developed countries, but in reference public health laboratories. But this is important. Obviously, we have to mention in association to do this that this is a notifiable disease globally, and it should be notified the health authorities. We have here another comment. Excellent discussion, sir. Can dengue vaccine give for immunocompromised patient of non-endemic country who in the future will go to endemic country? Right now, this vaccine is totally contraindicated among immunocompromised populations. There is no data in these populations. Even the licensing of these vaccines have some certain variation among countries. For example, there are countries where this vaccine is licensed for a population from 4 years old up to 59 years old. It's not licensed in some countries for people about 60 years old. But in other countries, there is no upper limit of age for the use of the vaccine in principle. But again, these need to be assessed carefully. Recent data, for example, from Argentina, is showing that it's safe even in elderly populations, and this is good, but it depends again on the country if it's licensed or not, for example, among elder populations. But specifically, among immunocompromised patients, is contraindicated globally. So far, this is not among the indications, and unfortunately, in this case, at least for now, these vaccines cannot be used among immunocompromised patients. There is here another question. Thanks, great presentation. Thank you, Shaima. If the patient diagnosed with yellow fever and he was diagnosed with one of hematological malignancies, what is the time gap should be safe between infection and restart chemotherapy again? Well, this is a very complex scenario because I am assuming that you're mentioned this overlap of both conditions. What is important is to try to avoid to immune suppress more the patient. We have certain times that we need to consider. The first is the viremia, and this is the more critical period for the disease. And the viremia is a time that goes between 7 of to a maximum of 14 days. That is a very critical moment. In that period of time, you will try to avoid any kind of management that implied immunosuppression in this patient. But later, if you have a patient that is not just with yellow fever, but in fact may go to severe disease, obviously, even beyond the viremia period, you will try to avoid chemotherapy, for example. But again, we need to balance between what is presenting actually the patient and the risk in this scenario to even induce a more severe disease. Usually, this will, again, 2 more additional weeks, and probably, if we may say, let's say rough time, probably that will be around a month. But again, you need to consider with this the clinical situation regarding the infection in the patient as well the immune condition. Here there's another question: how to evaluate immunocompromised status before vaccination? Well, this is a complex question because it depends on which disease specifically we are speaking. For example, if we are speaking, for example, with HIV patients, what is key is the lymphocytes, CD4, CD8, CD3. We may assess that, and particularly from CD4, as I already explained in the presentation, we may assess if we have a safe scenario, for example, for yellow fever, as well for other vaccines in the case of HIV population. But again, if you may speak from a more general point of view, again, we need to assess, for example, what is the levels of leukocytes, lymphocytes, if the patient is in general not immunosuppressed by the hemogram. This is an important assessment, but you may need to assess other with other tests depending on a specific disease you are considering, according to what you have and the type of immunocompromise, including not just cellular but also humoral immunity, which is also important to consider secondarily in this scenario. Here, there's another question. In South America countries, I assume, is yellow fever screening routinely done in blood banks? That's a very good question. And I must say it's not included in the routine screening in all the countries. And this has been a lot of discussion over the last decades, and right now again during the ongoing rates. But what I may tell you is that, for example, here in Colombia, as well in Brazil, which are both endemic countries for yellow fever, what is routinely done for the screening is for the case of transplant recipients. In transplant recipients, we are careful to assess very a common endemic pathogen that includes the case of yellow fever, the case of toxoplasma, which here is highly prevalent. Obviously, for example, other conditions that you don't have endemic, for example, in Europe, such as is the case of Chagas disease, which is caused by a parasite that can be detected in the blood, the T crucide, Trypanosoma crucide, which, by the way, right now, due to migration, is important in Spain and other countries in Europe, and you should screen, especially in migrant populations from Latin America, where you have that risk from blood as well from organ donation, and this should be considered also in the possibilities, and this is also very important to assess in migrant population. But even again, also for the case of yellow fever, if you have someone returning in the last 2 weeks from an endemic country, and it's even worse having fever, it's important to consider the possibility that this person may have, for example, a yellow fever. We have another question. In India, yellow fever vaccine is given to those traveling to endemic area. So for this, to evaluate immunocompromised status, what checklists for tests to be recommended, any guidelines? Well, the guidelines are those that I already mentioned. The ASCO from the American Society of Clinical Oncology, and the German that has been, in fact, recently published in Lancet Oncology as a policy review. This guideline of the Infectious Diseases Working Party of the German Society for Hematology and Medical Oncology. But beyond that, there is no currently available specific guidelines on this. I should mention that we are working right now with the European Society for Clinical Microbiology and Infectious Disease ESMIC study vaccines study group, EVAS, in the development of recommendations for the immunocompromised traveler in terms of vaccination. We expect to have this year, and we believe this will very important because we assess a very significant number of conditions with immunosuppression. We assess from the point of view of the vaccines and from the point of view of the travel risk, and this we expect will also help us in addition to the information I already provide. Well, the time passed quickly, and I would like again to give thanks to everybody that connect for this session that I think has been interesting and important, especially to highlight the ongoing situation with yellow fever in South American countries and the risks that are associated not just for general population, but also for immunocompromised patients, including those with hematological malignancies. I left in the chat my email. I will do it again. If you are interested on any further um, question or comment, or you are interested on the papers or the presentation itself, I have no problem to share it. Here I am sharing also my social media, and I think I even may share the file for you if you are interested in download the file of the presentation. I may do it here, the PDF. You may download. There is. If you are still interested, there is right now the PDF of the presentation is now shared in the chat of this session. It's uploading right now. In a few moments will be available to everyone. I would like again to close giving thanks to the working group of infections in hematology of the European Hematology Association. Thanks to EHA, thanks to John Salmaton, thanks to Janina Lecter and Volodymyr, and thank you very much again for everybody. Have a nice day, a nice week, and hope to see you again in a future webinar or in a future conference. Thank you very much.